Um, so for our upper evaluation for our elbow, me and my preceptor sat down and talked about elbow pathologies and a mock patient because we didn't have anyone present for us to be able to sit down and do that. So the hypothetical, so to give a little bit of background on the patient, the mock patient that we had was Sarah. She was a 23-year-old female who's a tennis player. The chief complaint was left elbow pain that had been increasing over the past month. Pain is described as sharp and aching, localized on the lateral aspect of the left elbow, 7 out of 10 during activity. Aggravating factors are backhand strokes, gripping the rackets, and wrist extension. Rest and ice alleviates the pain, but pain immediately returns during activities, so no numbness, no tingling, minimal swelling over lateral epicondyle of the left shoulder, no bruising, no visible deformities, and no skin conditions. As a mock patient, I would, after being provided with all that information, I kind of talked with my preceptor and I would have asked, more additional history questions before I went and moved on to range of motion. I would have asked about whether or not it moved up and down the chain, if they were having any additional issues with their wrist and shoulder, to see if they were compensating anywhere. I would also ask, are you taking any pain medications? What does your sleep schedule look like? What does your practice schedule look like, to see what that intensity looks like? What do they do? Another good question that my preceptor hit on was, what do they do over the summer? And are they left-handed? Because in the information being provided, they were saying that there is nothing about right-handed or left-handed dominant, so that would be something that I would have to double check to make sure. I would then go into my range of motions, my special testing for elbows, my test for flexion, extension, pronation, supination. I also would have tested for grip strength because they specifically mentioned that there was pain gripping the racket, so I want to see if there was any kind of deficit when it came to that. And then I would compare bilaterally. I'd move down to wrist flexion and then extension. My palpations, I would palpate the lateral epicondyle, the humerus radius, ulna, RCL, okernon process, your extensors, radial brachialis, your flexors, as well as your styloid processes. I kind of would just move my way up and down, making sure that if there's any super sensitive areas that I'm making sure that I target those. Special tests that I would have used on this patient, I would have used valgus stress test, Cozen's, Maudsley's, because I think that's a good one, especially with the extensors being having issues, and then Mills test. I would also, just to rule out any damage to the nerve, radial or ulnar nerves, I would just check for Tinel's on both bilaterally on both sides. So part of question 1 was my evaluation comprehensive? Why or why not? So unfortunately, because it's a mock, my evaluation is based off of the information that is being provided. So I think that sitting down and looking at it on a piece of paper, I feel like we covered a lot, and when I asked my preceptor if there was anything else they would have done differently, they agreed that my history taking and my evaluation, or my range of motions, were good, because there's not much else to do for the elbow besides flexion and extension. So I think I did pretty well there. Question 2 was, did my palpations and inspections and objective measurements lead to a confident diagnosis? So my first guess was tennis elbow. But when they came around to what the diagnoses were, it was tennis elbow and then radial tunnel syndrome, which it looks like from my special testing, those both would have ruled in from testing for Tinel's and then my Cosen's and valgus stress test and so on. So I think I did a pretty good job with having my special test kind of indicate whether or not the diagnosis or my diagnosis led, or how do I say that? Not led, but supported my my special test supported my diagnosis. So question 3 was, did I incorporate any evidence into my evaluation? Why or why not? No, not really. I think that's something that I still need to be better about, and I think that's just something where I need to sit back and look at all these new, the value of these tests. When I sat down and asked and talked with my preceptor about like what special tests that they would do, she said that 9 times out of 10 she will always go straight to valgus and varus stress testing, because that will indicate a lot. So I think just like just knowing, having a better knowledge of which ones have higher sensitivities and specificities is would be important. What did I do well? Discuss 2 areas. Well, I think I really did well with, again, kind of differentiating and isolating my diagnosis to what the issues were. I think I also did really well was kind of initiating additional questions, asking for more information, because I think asking for more information is always better than not. So yeah, I think those were 2 things that I did really well. Things I can improve on still. I think I could have, I felt like my palpations were thorough, but I think I could have done better with my palpations. I think, especially if this was a chain reaction, something was going on in the shoulder, I would want to check, for scap dyskinesis, because this patient does uses their arms quite frequently in tennis, so I would want to check to see if she any issues through that at all, which would have could cause strains down in the elbow. I think I could have also asked about whether or not the patient had any muscle weakness, so I could have done better about manual muscle testing. That information wasn't provided, but it kind of slipped my mind after I did range of motion, so just making sure that I'm always doing both range of motions and muscle testing just to see if I have any of those weaknesses. So yeah.